Hello everyone, my name is Zach Keebler. I am a molecular biologist. I worked for almost 10 years in an NIH-funded research laboratory, Department of Toxicology, studying ethanol metabolism, then worked and helped grow a business into one of the largest antibody and protein manufacturers and resellers in the world. And then after that company was sold, I started another company doing a similar thing, selling antibodies and proteins to researchers across the globe. Some of my customers are some of the largest research institutions in the world. I make these videos for family and friends in order to help them understand and see for themselves some of the data and information that scientists are working with so that they can make informed decisions on what they want to do with their lives and the decisions that they're making surrounding this current epidemic or pandemic. So today is May 11th, 2020, and we're going to dive in on a few different things here. I've got a quick little slide to go over those. So we're going to look at wearing a mask. I see a lot of people wearing masks, a lot of people not wearing masks. Why should we wear a mask? Putting on and taking off a mask safely is important. Disinfecting your masks, and some questions I got about carbon dioxide poisoning. Is that a concern with masks? So we're going to dive in a little bit into that. Then we're going to look at the fatality rate for the disease, best guesses based off of information and studies that we have from various sources. And then we are going to look at some of the reopening that we've been doing across the nation, why we're doing that reopening and what that means. And hopefully, given the information that you get earlier, you can make informed decisions on what steps you're going to take moving forward. So the first thing we're going to look at is why wear a mask. And where I want to take you is a couple of different places. First, to this study from Aalto University out of Finland. I apologize, I do not know the proper pronunciations for most of these universities and regions, so forgive me for the mispronunciations. This first one, researchers modeling the spread of the coronavirus emphasize the importance of avoiding busy indoor spaces. This particular study, a joint project carried out by 4 Finnish research organizations, looked at what happens when somebody is standing in the aisle of a grocery store and they cough. Where does the particulate matter from their cough travel? Where does it go to in the store? So let's look at that really fast. In the 3D model, a person coughs in a corridor bounded by walls, and as a result, aerosol cloud travels through the corridor. So let's look and see where it goes over time. So this is the individual coughing, and this is the particulate matter from their coughing. You can see it travels over next door, and it sort of travels over into the aisle 3 aisles over, and it probably would do that in the same direction elsewhere. The yellow are higher traveling particles, the blue are lower traveling particles, and over time it settles down. But what does this tell us? This tells us that the particulate matter from an individual who is coughing, who has the virus, can travel not just in the aisle that they're in the supermarket or grocery store, but in the aisle next door and even the aisle next door to that. Starts to get at why we should all be wearing masks. Let's look at one other little study that came out. SARS-CoV-2, that's the virus that causes coronavirus, the COVID-19 that we're experiencing now, found on particulate matter of Bergamo in northern Italy, first preliminary evidence. And what they discovered is RNA from this virus when they were looking at filters that were pulling in just the general air from Bergamo, and they were finding coronavirus. They were finding SARS-CoV-2 on these filters. So what that tells us is that this virus can travel significant distances. And it really gets at the question of, is this an airborne virus? And believe it or not, that's actually a really technical question. What does it mean for a virus to be airborne? It has a lot to do with how far it can travel from its source, how long it stays airborne for, and when we look at the information that we're getting from numerous universities, we're discovering that the SARS-CoV-2 virus can travel significant distances, which gets all the way back at our question of why do we wear a mask? Remember with this virus that you can be asymptomatic and be a carrier of the virus. So you can not have any symptoms, but you can be carrying the virus and expelling it into the environment around you without having any idea. And while you may not be concerned about dying from the virus, even for potentially legitimate reasons, you're a healthy young adult, that does not mean that the people around you are safe from the virus. And that does not mean that you can know for sure that you're safe from the virus because you may not know all of your underlying conditions. So when we wear a mask, when we put a mask on, we ameliorate or control the amount of virus and how quickly it can spread as we breathe out or as we cough. So I've got, a mask, one of the general masks that we've been using around the house and out in public here. When I cough and I don't cover my mouth at all, we saw what happened with the particulate matter from that cough in that first video. That cough and the particulate matter can travel all over the place. It's a little bit better when we go like this, but now we have the virus all over our hands or on our body, and it can be, we touch things. So when we wear a mask and we cough, I can feel the air come out the sides, but that air has been greatly slowed down by wearing a mask. It's not going to travel as far as if I didn't have this mask on. So the mask doesn't necessarily stop me from breathing in coronavirus, but it does, if I have the virus, it does keep the virus much closer to my personal self, and therefore can make, can keep somebody safer who may also be wearing a mask, may not be wearing a mask, who is in my general vicinity. So that's why we wear a mask. It's not necessarily because we think we're in danger personally. It's because we don't know who's around us and we don't know how much danger they're in. And everyone needs to be able to go do the essential things that they need to do to survive. They need to be able to go to the doctors. They need to be able to go to the grocery store to get food, the pharmacy to pick up medicine. They need to be able to be out in public as much as you do, and they need to be safe. So we wear masks not just for ourselves, but for everyone around us. There are other types of masks, and N95 masks are the ones that you see talked about a lot. This is an N95 mask that I've had for quite some time, from using it for painting and yard work and things like that around the house. This one is unused as of right now. N95 masks are different for several reasons. The two big ones are that they can control airflow around your face much better and what particulate matter is coming in. So you see this metal band up here. When you put on an N95 mask, this metal band should be bent like that to fit around the contours of your nose, which is a very bendy place on your face, right? So once it's properly on, once the mask is properly on, I don't have holes, and you can see in the inside of the mask there's actually a foam here. I don't have holes up in this area here. It's touching my skin all the way around, and although I have some facial hair, I have it cut so that it stops before it gets to this place on the mask, so that the mask is touching all the way around. So when I do breathe out or cough, I don't feel air blasting out any of the sides, okay? So I am greatly reducing the amount of air that is coming out from my face. And likewise, I'm not sucking air in that is not traveling first through this barrier. This barrier, as an N95 mask, is capable of blocking particles as small as the coronavirus. So the coronavirus, as I breathe in, is getting sucked in towards the mask, but it's stopping here. On this material, and it's not traveling through this material. And that actually can protect me from getting the coronavirus if the mask is worn properly, and if when you go to take it off, it is taken off properly. And that's a big issue. Wearing the mask properly, you can see wearing it properly here. This part is bent around the nose. I've kind of shown how to do that already. This part goes over the ears. This part goes under the ears. There is no hair coming through anywhere. There is a tight seal. Now that this mask is on, while I am out in public, I cannot touch the mask. I cannot move the mask. I cannot eat or drink anything. I cannot touch any of this because as I'm breathing out in public, I am potentially, we don't know, but potentially pulling coronavirus onto this mask with every inhalation that I make, all right? So this should be considered a red zone once you have gone out in public, as soon as you have stepped out of your car, so to speak, and you're going in the supermarket. You don't touch this, you don't do anything with this, no matter how uncomfortable you are while you're in public, or you lose the effectiveness of the mask completely. So make sure it is adjusted properly before you get out of your car. Once you get back into your car, you need to, assuming you have sanitized your hands, if you have not sanitized your hands, I have a mixture of 70% isopropyl alcohol in this spray bottle that I use. 70% isopropyl alcohol is effective at killing the SARS-CoV-2 virus. This 70% isopropyl alcohol I spray on my hands. Now I just touched this with potentially dirty hands, so this could still be infected. So I could spray my hands, and while they're still wet, cover the parts of this that I touched with the 70% isopropyl alcohol. Now my hands are clean, and I'm ready to touch my mask. Remember, this is the red zone on the outside of the mask, okay? So I put a finger behind the mask like this, and I lift it off and away from my face, and then I hold it like this and immediately cover it in excessive amounts on both sides, and my fingers are totally soaking wet now. Everything is soaking wet with the 70% isopropyl alcohol. I cannot now use this mask again for at least 10 minutes, if not longer. It's going to be off-gassing isopropyl alcohol. It's unsafe to wear. It's not ideal. You can do the exact same thing with this type of mask and spray it as soon as you've taken it off. So I have the mask on like this. I'm out in public. I come back. I disinfect my hands. And then I pull it off, maybe by pulling behind the ear like this. And then we spray the outside thoroughly and the inside thoroughly. And again, this mask cannot be worn for at least 10 minutes until the disinfecting agent has not only gone to work on the virus and killed the virus, but all the off-gassing from the isopropyl alcohol in this case has also been is also complete. There are other disinfecting sprays that you can use. They will have different effects. You can use 70% ethanol. Those are going to have different, maybe potential consequences. I would not reuse a mask that I sprayed with bleach because bleach off-gasses for a very long period of time. Look into what disinfecting agents you use, but if you can get 70% isopropyl alcohol, that is a great choice. It's completely dry and gone off of the mask because it is... it evaporates at room temperature, so it is gone within about 10 minutes off of these masks. All right, so that's disinfecting the masks. I had somebody ask, what about CO2 poisoning, carbon dioxide poisoning? I think that's a really, really good question. I actually tried to look into that a little bit. I went to this paper, Carbon Dioxide Rebreathing and Respiratory Protective Devices, Influence of Speech and Work Rate in Full Face Masks. They studied 40 workers. I looked at this one, our exhalation valves. Those are those little valves you see on the side of some N95 masks that let you exhale air. When you exhale, that extra pressure releases out the sides very quickly. Does that work better? It does seem to do so. I looked at this paper, Evaluation of Carbon Dioxide Rebreathing During Exercise Assisted by Non-Invasive Ventilation with Plateau Exhalation Valve. This is looking at COPD patients with COPD, and the effects of carbon dioxide rebreathing. All of these papers show that carbon dioxide breathing does occur. It shows it occurring at different levels under different circumstances. I cannot find a really good longitudinal, long-term, large population study on the effects of carbon dioxide rebreathing. All of that to say, there are professions that wear N95 and similar masks who live under carbon dioxide rebreathing conditions on a daily basis for hours at a time, and we do not have any significant reports showing any danger to those individuals. But if you are not a normal, healthy adult, then I would speak to your doctor about any concerns they may have with carbon dioxide rebreathing if you're a COPD patient, for example, and what your concerns should be with wearing a mask, because it is a consideration. You do increase the amount of carbon dioxide that you're rebreathing by wearing a mask. But again, not necessarily dangerous for normal, healthy adults. So now we get into, I want to get into the fatality rate. I have a lot of friends and family asking, what's the fatality rate from this virus? And that's a great question, and it's a tough question to answer. So we're going to look in a couple of different places. Okay, so Nature news article. Nature is one of the more prestigious scientific journals. Antibody tests suggest that coronavirus infections vastly exceed official counts. I viewed that as generally good news, because that meant that we were getting, I was hoping, closer to that 70%, 60 to 70% of the population who has to have the virus in order to start developing what's called herd immunity, where the virus runs into so many people who have had it and are immune against it that it really isn't able to effectively spread. That's herd immunity. So I dove in on this, and unfortunately didn't find that we were anywhere close to that 70% of the population, but we did get some really interesting information from here. So there was a couple places that they looked at in Santa Clara, where they estimated that there was, they estimated a death rate of 0.1 to 0.2% of the population. They looked at China, but more interesting to me was this Diamond Princess cruise ship, where a whole huge swath of people in a very controlled environment got the virus, and 0.5% of the population from that cruise ship died of the virus. So that's kind of a really great control group, right? We didn't expose them to anything else. They were probably a little on the older side than the general population, but I don't know specifically. I didn't look at all the demographics for the cruise ship, but we got a fatality rate of 0.5% off of the Diamond Princess cruise ship. And in China, the numbers have been kind of changing based off of data as it's released out of China. So we're being cautious there. So then I wanted to let's look at another place. Let's try and get some more data to get a better feel. This is the article that was published. 1 in 5 people tested in New York City had antibodies for the coronavirus. Great, because again, we're getting closer to that 60 to 70% we need for herd immunity. All right. It was updated as of April 27th. It was originally written on April 23rd. And when we dive down into the article here, what we see here, this paragraph, if the actual infection rate among the entire population is similar to the early sample infection rate they found of 13.9%, it would change the death rate of the state, Cuomo said. New York is reporting 15,500 COVID-19 deaths. That was as of the 23rd or 27th. And if 2.7 million people were infected, that would mean the death rate would be about 0.5%. So again, we're seeing the 0.5% fatality rate for the virus, at least in the United States. And then I went to another article. This is Health Affairs. This is actually a research article estimating the infection fatality rate among symptomatic COVID-19 cases in the United States. This is written by Dr. Basu out of the University of Washington in Seattle. And what we see here, you can dive into the whole article if you'd like yourself, but they come to the conclusion that the fatality rate is estimated to be about 1.3%, with confidence intervals between 0.6% and 2.1%, or allowing us to believe that the fatality rate somewhere is in the range of 0.6% to 2.1%. Okay, so and this paper goes into great detail about how they came up with those numbers. They look at confounding variables. They look and compare that to the flu rate, the overall flu rate, which is 0.1%, and they think it's somewhere around 1.3%, but they're 95% confident in the range of 0.6 to 2.1%. So we're going to take all of that and we're going to conservatively say the fatality rate is around 0.5%. Now, this article says, and other places have said, that is all completely dependent on having enough ventilators and rebreathers and all the equipment and doctors and beds we need to treat those who become seriously ill, because the number of seriously ill who do not die is much, much, much higher than 0.5 or 1.3%. It's like 10, 15%. So we need to be able to treat those people or this death rate will increase significantly. But let's say it's 0.5%. We're basing that off of the Diamond Princess cruise ship rates. We're basing that off of New York City's cruise rates. New York City's death rates, and a low-end estimate off of this particular paper. This paper pulls real data from Johns Hopkins University. You can pull that data as well. So if you go to their citation number 6, Johns Hopkins University COVID-19 data repository. You can actually click directly through that. This is where you will land. This is raw data, and you can scroll down for the latest data on deaths, and when you click through to that, you can get the death counts and things that are coming through. So confirmed cases, deaths, recovered, and active cases for a whole bunch of cities in the United States. It's great data. This is coming directly from Johns Hopkins. What I wanted to do is, since we have a larger sampling of who has had the virus in New York City, they went out and just randomly tested a few thousand people in New York City and found around 20% of them had the virus. I wanted to dive in on New York City's numbers to see if maybe we could get a better feel for what the fatality rate is by age. So 0.5% fatality rate, that's 5 times the mortality rate or fatality rate for influenza. Okay, so that's much greater than influenza, but that's also over the whole population. So that rate is going to be much higher in certain demographics and lower in other demographics. And as we would guess correctly, it is higher in the elderly population and lower in younger populations. I was able to find the New York City Health PDF. You can go again to this and you can change by date, and they have a death count by confirmed and probable cases. What is confirmed and probable? Confirmed are they were the decedent, the person who died, was a resident of New York City and tested positive for SARS-CoV-2 in laboratory tests. And probable, they were a resident who died. They didn't have SARS-CoV-2 testing, but the death certificate lists SARS-CoV-2 as the cause of death, or COVID-19 symptoms as the cause of death. How conservative is that? I want to take you to the CDC's website on provisional death counts for coronavirus. This is updated as of today, May 11th. And we jump down here into read this whole article, actually, if you can. Go to this web address that's up here. Read this whole article, and what they do is they break down for you exactly what it means to be conservative on coronavirus death counts and liberal on coronavirus death counts. The conservative number as of May 11th, 2020 is 49,867 deaths from coronavirus. These are deaths where the doctor said, no question, these people died from coronavirus. And I just messed it up, so let's get that corrected there. Okay, these people died from coronavirus. The doctor is convinced of that. They've been tested positive for coronavirus. They were in direct contact with people who were sick and had tested positive for coronavirus. No reason to believe that there was any other reason. But we actually have a baseline death rate in the United States. We know how many people are going to die on average from all causes. And we started seeing that death rate increase in the United States as we fell under the effects of this virus. And we started seeing our percent of expected deaths going way above normal on a weekly basis. And we started seeing that our pneumonia deaths, where doctors were saying, I think that this person died from pneumonia, were spiking way above normal. Instead of the 3,600 to 3,700 number of deaths that we see on a weekly basis, we were seeing, in this on April 11th, we saw 10,658 death certificates read pneumonia as the cause of death. So what the CDC is arguing in this section is that coronavirus deaths are actually probably higher than the guaranteed 49,867, and somewhere around 107,825 deaths that are either from coronavirus, pneumonia, influenza, something along those lines. It's actually really hard to say as a doctor what was the cause of death. You know your patient had pneumonia. You don't know whether they had SARS-CoV-2 or not for sure. What do you put as the cause of death? You might put pneumonia in that case. You know your patient had pneumonia. You know your patient had SARS-CoV-2 for tests because they're testing, but you think they died from pneumonia. What do you put as their cause of death? That's what they're trying to capture here. The CDC is trying to capture. The really conservative estimate for deaths is 49,867 as of today in the United States, and the very liberal count is 107,825, which is why you will see the actual count released by the CDC as a number somewhere in between these two, as a fairly liberal but not entirely liberal estimate of the number of deaths. Okay, so New York City bases this confirmed cases and probable cases. They work in the same way. They're coming up with numbers in kind of the same calculated and careful way. These confirmed cases are absolutely no question they died from SARS-CoV-2, and probable are they were, all the symptoms were there. They were in contact with people who had it. They likely died from SARS-CoV-2. Okay, and then they actually don't list. They have a whole other section. They're not including not known to be confirmed or probable. If they're not known to be confirmed or probable, New York City Health is not counting them as a SARS-CoV-2 or COVID-19 death. And I actually went and jumped to the report for the 27th of April in order to match this information that we got from Governor Cuomo's office on the number of people who had been tested at the exact same time, and where we get this 13.9% infection rate for the state, etc., because I wanted to do a breakdown for the population of death rate by age. I got the ages from this the ages of population of New York City from this 2016 data. It's going to be off a little bit. They're showing 8.5 million people in New York City in 2016. We know that now that it's a little bit higher than that, but generally speaking, the demographic breakdown of the age population in New York City will not have changed greatly from 2016 to 2020 today. The percentage of people that are in each age group. So I used this data on just a count for how many people are in each one of these age groups, and we created this data set here. So this is the same New York City data as of 4/27/2020 that we saw on the New York City Health's PDF. It's just literally copy-pasted over. Okay, and we have deaths confirmed from SARS-CoV-2 and probable from SARS-CoV-2. We had a New York City population of 8.4 million people. At the time, again, according to the office on this date, Governor Cuomo's office, 21%, based off of a random sampling of the population, had tested positive for SARS-CoV-2. Now, you could make some arguments that sampling wasn't particularly random. It was people who were out and about. It was generally older adults, whatever the case may be. But we're going to get as close as we can with this data. So given a population of 8.4 million and 21% positive, we have 1.764 million infected New York City residents as of April 27th. All right, then we need to break down by age group the number of people within that age group. Okay, so they're roughly speaking, that's what that little tilde means, 1.816 million people in New York City who are between the ages of 0 and 17. Okay, so that's 21.2% of the population. There are roughly 3.461 million people between the ages of 18 and 44, or roughly 40.8% of the population. Okay, you see how that breaks down? So we've got, you add these all up, that's 100% of the population that is accounted for here. So we divide the total number of 1.764 million based off of the 21% infected probables, and we get our infected rate for each age group. And then we look at our total deaths of confirmed and probable, and we get a final fatality rate. So, great news, first of all. In the 0 to 17 year old age group, we have a 0.002% fatality rate. Super duper low. That's fantastic. Children are very unlikely to die from this. But again, underlying symptoms, immunosuppressed kids, children with other complications may die from this, or could die from this. There are at least 7 deaths in that age group in this time period. I think going back to around March 11th is when they started recording. We look at the 18 to 44 group. That's the group that I'm in. 0.08%. Okay, this is almost 0.1%. And that is almost the general mortality rate for influenza. But remember, the 18 to 44 group doesn't have a 0.1% fatality rate from influenza. Like coronavirus, it's a much lower fatality rate for the 18 to 44 group because they are, generally speaking, more healthy. So 0.08%, that's pretty good, but it's starting to get up there. The 45 to 64 group, this is almost to a full percent, 0.78% death rate in this population in the 45 to 64 group. This is well beyond the 0.5% average because the younger groups are bringing that average down significantly. This is 8 times the influenza rate, and it gets much worse from there. The 65 to 74 have a 2.8% fatality rate, and the 75 and over have a 7.3% fatality rate. The elderly population is at greatly increased odds of fatality from this. We have male and female, and then we have boroughs of residence. I didn't break those down. I wanted to look at fatality rate by age. This is a very, very dangerous virus for, I would say, the 65 and over group. At 2.8%, you have a shockingly high chance of dying from this virus if you get it. And at 7.3%, that's pretty terrifying. 1 in almost 10, 1 in 15 or so are going to die who get this virus who are 75 and over. Now, obviously, the older you are, the more pre-existing conditions that you have, the more what they call comorbidity factors. If you're a smoker, we don't know. I've seen reports that say that some smokers are actually more protected for some reason. If you have COPD, if you have a compromised immune system for any other reason, your numbers are going to be higher. This virus is not done yet. When we see that 21% of the population in New York City has had it, we're nowhere near the 60 to 70% that we need for herd immunity. So why are we opening back up? And that gets into kind of my final section of this talk. I wanted to look at Colorado, not just because that's where I live, but actually it's a really interesting comparison to New York City. New York City is a very densely populated city. Colorado is not nearly as densely populated, and Denver even is not nearly as densely populated. We have numbers in Colorado right now, 944 deaths, based off of a 0.5% fatality rate. I'm estimating somewhere around 190,000 people infected in Colorado, which is only 3.2% of the population being infected. In Denver, there's been 195 deaths as of today, 39,000 infected, which would be 6.2% of the population. So when we go all the way back to the beginning of this discussion and we look at how easily this virus can travel through the air, travels over, the aisles in the grocery store, it travels and gets picked up by air filters that are being used for other studies by research scientists. It does not surprise me at all that New York City has a 20% infection rate, and that Denver has a 6% infection rate, and that Colorado has a 3% infection rate. And some of those infection rates are much higher in some of these more densely populated mountain towns where we got really hit here in Colorado. Population density is going to increase the rate at which the population picks up the virus. So we're nowhere close to the 60% to 70% that we need to reach herd immunity. We do not have a vaccine to keep people from getting this virus in the first place. We do not have any approved effective methods for treating this, although I would like to see some more research done on early stage testing for some of the treatments that have been discussed earlier. So without any of these, we have to get to that 60 to 70% of the population before the virus is done and kind of peters out. Without a vaccine, without a treatment or cure of some kind, there is no reason that this virus will stop until we get to that 60 to 70%. But in the lockdown process, while we really flattened the curve, and here in Colorado didn't come close to filling all of the hospital beds and emergency hospital beds that were put into place, we did dramatically slow the economy. And, we have seen some real deleterious effects from this much sequestering. So why are we opening back up? Because our hospitals can take it, and frankly, we need to increase the infection rate until we get to that 60 or 70%. Because in lieu of a vaccine or a treatment of some kind, we will not stop the spread of this virus, no matter pretty much what we're doing, until we reach that herd immunity stage. With a 0.5% mortality rate, that means that 1.5 million people, if 100% of the population were to get it, would die in the United States alone from this virus. We're somewhere around 100,000 so far. So we are a long ways away from the number of people that could potentially die from this. I'm starting to see numbers that by the end of the summer, we will be at about 500,000 deaths from the virus. This virus has not begun to hit the more rural parts of the United States because the population density simply isn't there. So from a balancing perspective, from a economics in balance with danger and health and hospital bed capacity, we are opening back up so that people can choose whether to go back into society at some level, although there are many people who cannot choose. And the fact that they're being exposed without having a choice over the matter is a tragedy. They should have a choice of whether they would be exposed or not, especially in the more, the elderly populations, those at greater risk from death from this. We have to do that balance. If we were to remain completely closed down, we could be looking at complete economic collapse, and nobody wants that. Maybe there are some methodologies that could be used by our government to ameliorate the effects of being shut down like that, but it has not been effectively done so far. So we need to open back up at some level to get the economy going at a level that it can sustain without collapse. And we can handle it. Our hospitals are not overwhelmed, and we are not passing it along at a rate right now that can overwhelm them. So this opening back up, in my mind, is a way for the government to very slowly increase our infectivity rate at a rate that we can handle and cover in hospitals, but also to get us to that 60 to 70% of the population being infected to reach herd immunity. Whether or not you want to be a part of that 60 to 70% is probably going to have a lot to do with your age group and other susceptible and comorbidity factors that you have to take into account, not just for yourself, but the people that you interact with. So you have the data now for yourself to decide what you're going to do, and you have information on mask wearing that can help others, not just yourself, but others around you, in consideration of what they may be facing as an individual and the mortality rates for this virus. So please stay safe out there. Thank you for watching. Again, if you liked it, please provide a thumbs up at the bottom. I love comments. I will make another one of these as more questions come out. It was great talking to you all, and we'll see you soon.